Welcome back to Learn with MedNuggets. Today we are breaking down the basics of ECG interpretation. Whether you are a medical student, a healthcare professional, or just curious about how an ECG works, this video will simplify the key concepts for you. Let's start with the blood supply of the heart. The heart is primarily supplied by two coronary arteries, the right and the left coronary artery. The right coronary artery supplies the right atrium and the right ventricle, and it branches into the right marginal artery that supplies the right ventricle and the apex. The left coronary artery branches into the left anterior descending artery and the left circumflex artery. The left anterior descending artery supplies the right ventricle, left ventricle, and the interventricular septum, and the left circumflex artery will supply the left atrium and the left ventricle. Next, let's discuss ECG leads and electrodes. In a standard 12-lead ECG, 10 electrodes are used to record the heart's electrical activity from different angles. These electrodes are placed on the limbs and the chest, giving rise to 12 leads. There are limb and precordial electrodes. There are 4 limb electrodes. These are placed on each of the patient's limb, that is in the right arm, right leg, and the left leg. These electrodes help create 6 leads that view the heart from different angles in the frontal plane. Leads 1, 2, and 3. These are the bipolar limb leads, meaning they measure the electrical difference between two electrodes. Lead 1 measures between the left arm and the right arm, lead 2 between the left leg and the right arm, and lead 3 between the left leg and the left arm. Leads AVR, AVL, and AVF. These are augmented unipolar leads, where the electrical activity is measured at one point and referenced against a combination of the other electrodes. AVR will look from the right arm, AVL looks from the left arm, and AVF looks from the left foot. Then we have 6 precordial or chest electrodes. These are placed across the chest, V1 to V6, giving rise to 6 unipolar precordial leads. These leads record the electrical activity in the horizontal plane, viewing the heart from different angles around the anterior and lateral walls. For example, if you take lead V1 and V2, these are placed over the right ventricle and the septum. V3 and V4 will look at the anterior wall of the left ventricle. V5 and V6 will look at the lateral wall of the left ventricle. Together, these 12 leads provide a comprehensive 3-dimensional view of the heart's electrical activity. Moving on to the waves that are seen in ECG, the electrical activity, as we all know, starts in the heart's pacemaker, which is the sinoatrial node. This will depolarize the atria, and this depolarization of the atria is represented by the P waves in the ECG. Then this electrical impulse goes to the atrioventricular node and then goes to the bundle of His and depolarize the ventricles. And this is represented by the QRS complex in the ECG. And then the ventricular repolarization will be represented by the T wave in the ECG. The PR interval or the PR segment shows the time from atrial depolarization to ventricular depolarization. And the ST segment represents the early part of ventricular repolarization. The PR interval usually is 0.12 to 0.22 seconds, that is about 3 to 5 small squares. And the RR interval is about 3 to 5 large squares, and the QRS interval is usually less than 3 small squares. When interpreting an ECG, the small boxes and large boxes help measure time. One small box represents 0.04 seconds and an amplitude of 0.1 millivolts. And one large box, which is made up of 5 small boxes, will represent 0.20 seconds and an amplitude of 0.5 millivolts. In calculating the heart rate, we can use the 300 rule. That is, divide 300 by the number of large boxes between 2 consecutive R waves. This gives an approximate heart rate in beats per minute. As you can see in this example, there are 4 large boxes between 2 consecutive R waves. Therefore, the heart rate will be 300 divided by 4, which is 75 beats per minute. For fast rhythms, you can use the equation 1500 divided by the number of small squares between RR waves. The rhythm refers to the regularity of the heartbeat. A regular rhythm means the distance between the R wave is consistent, like in the ECG above here. In an irregular rhythm, the R waves will be unevenly spaced, like the ECG here at the bottom. The most common irregular rhythm is atrial fibrillation, which we will discuss later. Moving on to the cardiac axis. The cardiac axis refers to the overall direction of the heart's electrical depolarization. On a normal ECG, the axis can be determined by looking at the limb leads, especially lead 1, 2, 3, and AVF, which help identify if the axis is normal, deviated left, or deviated right. A normal axis is between minus 30 and plus 90 degrees. On an ECG, this will typically show a positive QRS complex in the leads 1, 2, 3, and AVF. This means electrical impulse is traveling normally from the sinoatrial node in the right atrium down towards the left ventricle. Then the abnormalities in the cardiac axis are left axis and right axis deviation. Left axis deviation is when the axis shifts to between minus 30 and minus 90, which often is seen in left ventricular hypertrophy or conditions like left bundle branch block. In left axis deviation, lead 1 is positive, but lead AVF 2 and 3 are negative. This is because, as you can see, the arrow is pointing upwards away from lead 3, AVF, and lead 2. While in right axis deviation, here the axis is more positive than plus 90 degrees, often seen in conditions like right ventricular hypertrophy, pulmonary hypertension, or a large pulmonary embolism. In right axis deviation, lead 1 is negative and lead AVF, lead 2, and lead 3 are positive. And this is because, as you can see, in right axis deviation, the arrow is pointing towards lead 3, AVF, and lead 2, and away from lead 1. Now let's move on to some abnormalities that can be identified with an ECG. ST segment elevation myocardial infarction. This is when there is a complete blockage of a coronary artery, leading to a significant ST elevation in 2 or more contiguous leads on the ECG. If the abnormality is seen in V1 to V4, that means this is an anterior or anterior septal myocardial infarction, where there is a blockage in the left anterior descending artery. If the elevation is seen in V4 to V6, AVL, and lead 1, this is a lateral myocardial infarction, means a blockage in the left circumflex artery. If the elevation is seen in lead 2, 3, and AVF, this is an inferior myocardial infarction, means the blockage is in the right coronary artery. As you can see in this example, you can see that there's an ST elevation in lead 2, lead 3, and lead AVF. So this is an inferior myocardial infarction, and the blockage is in right coronary artery. In non-ST elevation myocardial infarction, there is a partial blockage. Therefore, there is no ST elevation, but they can have an ST depression or a T-wave inversion. Now let's look into some common arrhythmias that can be identified with an ECG. Ventricular tachycardia. Here there is a rapid heartbeat originating from the ventricles, often seen as a wide and fast QRS complex. As you can see in this ECG, the QRS complex is more than 0.12 seconds. In supraventricular tachycardia, this is a rapid heart rate that originates above the ventricles, where they will have a narrow QRS complex that is less than 0.12 seconds. Ventricular fibrillation. This is a life-threatening condition. This is a little bit difficult to differentiate with the ventricular tachycardia, but with a clinical presentation you can, because in ventricular fibrillation, usually these patients are unconscious. In atrial fibrillation, this shows an irregularly spaced R wave and absent P waves, indicating a disorganized atrial rhythm. These patients usually have an irregular rhythm. In atrial flutter, they have a sawtooth pattern of multiple P waves for each QRS complex. Moving on to heart blocks. Heart blocks occur when there is a delay or block in the electrical conduction system of the heart. In first degree heart block, there is a prolonged PR interval without any missed beats. In second degree heart block, this can be Morbid's type 1 or Morbid's type 2. In Morbid's type 1, the PR interval will be progressively increased and then there will be a drop beat. In Morbid's type 2, the PR interval is constant but there is a drop beat. And in third degree heart block, there is no relationship between the P waves and the QRS waves. In right bundle branch block, the QRS complex will be wide with an M shape in V1 and V2 and a W shape in V5 and V6. While in left bundle branch block, they will also have a wide QRS complex with an M shape in V5, V6 and a W shape in V1 and V2. This can be easily remembered with the mnemonic Marrow and William, where in Marrow, the M in front means the pattern in V1 and V2 and W is a pattern in V5, V6 and the double R indicating a right bundle branch block. And in William, W in V1 and V2 and V5, V6 the M pattern and the double L indicating a left bundle branch block. Moving on to changes that are seen in hypertrophy. So left ventricular hypertrophy causes large R waves in the lateral leads, V5 and V6, and deep S waves in the right precordial leads, which is V1 and V2. Right ventricular hypertrophy results in a dominant R wave in V1. Atrial hypertrophy shows abnormal P wave. There will be a peaked P wave in right atrial hypertrophy, which is also known as P pulmonale, and a wide and notched P wave in left atrial hypertrophy, also known as P mitrale. Next, electrical imbalances, particularly potassium, can significantly affect the ECG as well. In hyperkalemia, you'll see peak T waves, a long PR interval, and a wide QRS. On the other hand, in hypokalemia, there will be flat T waves, prominent U waves, and possibly ST depression as well. Finally, in pericarditis. So pericarditis is an inflammation of the pericardium, and on ECG, it presents as a widespread saddle-shaped ST elevation, which is often seen in multiple leads without reciprocal ST depression. That concludes our ECG overview. I hope this helped clarify the basics and some advanced concepts in ECG interpretation. Make sure to practice regularly and correlate these findings with clinical symptoms for accurate diagnosis. Don't forget to like, share, and subscribe for more medical content. Thank you.